Okay, can you guys all see that?
Yes, very well, thanks.
All right, here we go. So we have a 24-year-old male patient who has history of multiple brain injuries, the first being several years ago in 2017. He had traumatic impact injury and 2 concussive injuries. The most recent was in 2021. So the patient has a social history included being in the military, doing artilleries, and being around a lot of things while they're being shot. He also sustained nerve damage, status post, black widow spider bite 2 times. He has a past
Imagine being in the
history.
military.
Sorry, what?
Good. Sorry, I couldn't imagine being in the military, what some of these guys have to put up with, but go ahead.
No, me neither. So he has a past medical history, including history of 8 microbrain lesions described in his imaging reports as baby MS. One of these lesions is in the optic nerve. He retired from the military in 2022. And at that time, he was seeing pretty well. However, it was thought that he had poor vision from previously sustained nerve damage. His vision has improved starting about a month ago. So in 2022, his vision declined and then returned later the same year. There's no chance that he has MS according to his testing. So when we saw him, his vision was 20/32 in J1 in both eyes, and his pressure was 13 OU.
Actually, these are tough images. Why don't you do this one? No, you can go later.
Color from this photo for right eye, media is clear, nerve looks pretty normal, maybe some temporal power.
Can you guys hear him? He's talking a little loud.
Media is clear, the nerve looks pretty normal, maybe. I don't think there's any temporal power. The fovea looks normal.
Perfect.
Similar picture in the left eye, the veins look a little bit more dilated. Nerve looks similar, they're similar cup to disc. Fovea looks normal.
Sorry, I'm pushing advanced. My computer's just lagging.
Okay.
This is an FAF showing hyperautofluorescence around the fovea.
And it's the same picture, just zoomed in.
Similar in the left eye.
Okay, so for the OCT, we have several horizontal sections, so I'll just kind of scroll through them to give you an idea, and then we can go back to whichever one you'd like, and you can describe it.
The fine grid OCT of the left eye showing outer retinal and some RPE disruption and like a little cavity in the foveal area.
RP looks okay. I think.
Yeah. The RPE looks like it's just outer retina, like photoreceptors mostly too.
And then we'll do the right eye.
Similar to this eye.
So this is tough, actually. So what for outer retinal loss? And
so this could be maybe with the history of trauma, I had a traumatic macular hole that closed by itself in both eyes. Could be Mactel, other retinal degenerations or dystrophies.
Yeah.
I think solar retinopathy, but it's pretty small. Laser beams are pretty small. Lasers, I think, mostly get the RPE.
Yeah, I don't see anything like RPE.
Yeah, laser pointers.
Transmission.
Could be. I'm thinking, go ahead. Something one more.
Like a reticular lesion that's kind of in a transition phase.
Yeah, good.
Okay, so the family history is pretty interesting. Our patient has a sister who's 5 years older than him, who is also Dr. Cohen's patient, who was last seen in 2020. She's worn glasses since she was a child, but since becoming an adult, her vision started to deteriorate rapidly. This has been happening since she entered the accounting department over the last 2 years. Her vision is worse in the light, especially when driving. She can see green lights in the night, but not in the day. She also sees better on a dark background than on a light background. Her mom, and our patient's mom, is genetically visually impaired with Stargardt's disease. She was tested in Boston about 23 years ago when the gene was first being isolated. The mother has 7 brothers and sisters, 4 of which who have Stargardt's and are legally blind. Also, one cousin has Stargardt's, so extensive family history. Her father has RP, so kind of unlucky genetically there. Her vision is 2160 -1, but pinholes to 2080. In 2160 -2, also pinholing to 2080 -1, and then 2200 -2 and 1, respectively, near.
He's trying to advance. Okay. So
And
this
then
is-
these are our patient's sister's photos.
So this photo shows some foveal hypopigmentary changes. And some RP changes. Same thing on the side.
It's interesting.
So the FAF shows modeled hyper and hypo autofluorescence and the foveal area in both eyes.
And then this is just a single cut.
So this one's showing outer retinal loss and probably a little bit of RP, definitely.
You can see the light going through it. Yeah, great.
Similar to this side.
All right. So for our first patient, the brother, we went ahead and got some genetic testing. As you can see, we were looking for the ABCA4 gene, which came back as pathologic. And then
It's interesting, there were 3. If you look, I've never seen 3 variants. People, I don't think that hard about it. Are you doing genetic testing in your talk?
A little bit, but I didn't go into the different variances and things. I read about it a little.
Not so much the variants, but like the segmentation, like these can be. Like the variants clearly can't all be on different chromosomes because there are 3 of them and you only have 2 chromosomes, 2 chromosomes for each. So I think you can get multiple variants on one chromosome. People say that if you're really diving into genetic testing, which I haven't done, I do it a lot, that you should maybe test family members and parents to really figure out whether it's, a little more about it. I don't understand that perfectly, but. All right, go ahead. But this was interesting because there are 3 variants there.
Yeah.
One says it's benign, but.
And then our second patient, our original patient's sister, was tested previously and was also pathogenic for the ABCA4 gene.
They match the variants? I didn't even look. You go back. 5, 4, or that one does,
Yes,
and-
they were
yeah, 5,
matched.
8, okay, that's good. So they're actually sisters.
They are indeed related. All right, so they both are positive for Stargardt disease, and we'll talk a little bit about that. So Stargardt disease is the most common juvenile macular dystrophy and most common cause of vision loss in adults younger than 50 years old. Visual acuity typically ranges from 20/50 to 2200, with the classic phenotype being characterized by juvenile onset foveal atrophy with a beaten bronze appearance, surrounded by discrete yellow round or pisciform flecks at the RPE level. So on fluorescein angiography, 80% or more patients have a dark choroid due to blocking of choroidal fluorescein, which you can see here. And then fundus autofluorescence demonstrates peripapillary sparing, central macular hypoautofluorescence, and over time an outward expanding pattern of hyperautofluorescent flecks, which leave hypoautofluorescent areas. OCT being used more often in the study of Stargardts allows early detection of lipofuscin accumulation in the RPE and photoreceptor layer disorganization. So the pathophysiology, the majority of cases of inherited Stargardt disease are autosomal recessive. Autosomal dominant transmission does exist, but is significantly less common due to mutations in the ABCA4 gene, which was seen in both our original patient and his sister. ABCA4 gene encodes an adenosine triphosphate binding cassette transporter protein, which is expressed by the rod outer segments and the RPE. So this leads to compromise of those cells and degeneration of the photoreceptor layer with death to the RPE cells, consequently leading to vision loss. So there's a broad spectrum of phenotype in Stargardts. Even within the same family, different ABCA4 allelic combinations can be responsible for distinct phenotypes, as shown earlier between the brother and sister that were presented. Stargardt disease can present with milder, less severe, and later onset subsets of the disease. The clinical phenotype of Stargardt is significantly influenced by age at time of diagnosis and accordingly progression of the disease. ABCA4 heterozygote carriers have an increased risk of developing AMD, but that's still speculative at this time. So for management, Stargardt disease remains an incurable condition. There's a lot of therapeutic options, including photoprotection and low vision aids that are currently recommended. Based on animal models of ABCA4 related disease, vitamin A supplementation accelerates the accumulation of lipofuscin pigments in the RPE, and in conjunction with blue light accelerates retinal death, so should not be recommended. Drug therapies to reduce lipofuscin accumulation, gene therapies, and stem cell treatments are currently undergoing clinical trials. And these are my sources. Just to touch on the testing that you were talking about, Dr. Cohen, what I was reading is that most of the, there's no prognostic value and it doesn't really change prognosis, final visual outcome, or anything depending which specific ABCA4 variant was looked for. So they kind of shoot for all of them to see if you have one, but as soon as it's positive, there's really nothing else to do with that information.
And this was a weird inheritance, so presumably the mother had both bad genes and the father must have had one or maybe even both too. So the kids were kind of doomed.
Yeah.
You know?
So could this be a cone dystrophy? Like with the
Oh, the pictures.
yeah.
Yeah, the pictures
Like
could have been
decreased
cone.
vision at night
Yeah.
or decreased vision during the day.
Stargardts, they don't complain about that.
And this patient was
Yeah.
yeah.
Yeah,
And I think this patient was pretty young, so we may not see the fiscal point flex.
right.
But maybe I didn't see any in the sister, but the sister does not have the same thing.
Yeah, the pisciform, so if you see flecks that are tri-radiate, they they look like they're three points on them. That's a typical Stargardt's fleck. And if you see one of those, it's probably Stargardt's. All right, nice job. Thanks.